To the best of my knowledge, I am the only non-clinician ever elected to the AVA Board of Directors, and I'm now serving as treasurer of the organization through 2020. I believe that will be nearly 5 years on the board, which would be a long time even for a clinical person. There are two things that inspire me weekly in this position. First is education. I'm constantly learning from the interaction with clinicians, and I think this makes me better able to understand the pressures, the limitations and risks, but also the opportunities to improve the quality of care for our patients. Conversely, I'm also hopefully teaching clinicians to understand the importance of integrating legal concepts into their work practices, such as meeting the evidence-based standard of care and the potential liabilities it may attach for failing to meet those standards. The second thing that inspires me is growth. It's very empowering to see the growth of AVA over the last few years. The 2019 conference is the largest conference to date, and vascular access is finally beginning to get the recognition that this long overlooked specialty deserves, both in terms of its impact upon the quality of patient care and the often underappreciated risks and liabilities attached to the insertion, care, and maintenance of intravenous devices. As a board member, I've been able to participate in assisting in the growing recognition of this specialty by contributing to initiatives such as the ECRI Top 10 Patient Safety Concerns, which now include peripheral intravenous infections, and the recent ICPIC Infection Prevention Conference held in Geneva, sponsored by the World Health Organization, that now has an entire vascular access program integrated into their agenda. Underappreciated, underrecognized, and most often ignored are the infections associated with peripheral vascular access devices, or PVADs, short peripheral catheters and midlines. This has been a passion of mine since my beginning with AVA years ago, because as a layperson, I was shocked to learn that while the potential adverse events associated with this line could be as equally problematic as any other catheter, no one seemed to pay very much attention to the PIV. The recent JAVA study conducted by AVA reinforced the fact that even graduate-level clinicians felt uncomfortable performing PIV therapy and expressed a lack of confidence in their PIV catheter skills. Yet this is the most common invasive device used in hospitals today, with nearly 200 million insertions yearly in the United States alone. Articles such as the 2015 article by Robert Helm, Accepted but Unacceptable, Peripheral IV Catheter Failure, have done a lot to publicize the fact that this most common of intravenous devices is failing at completely unacceptable rates, often greater than 50%. And these failures all too often lead to an avalanche of adverse consequences for our patients, including phlebitis, infiltration, extravasation, occlusion, dislodgement, and infection. And yet, despite these significant consequences, adverse events caused by this line are not tied to reimbursement, nor is there a clearly defined intervention bundle, and therefore there is little respect for this most commonly used invasive device, and sadly, very little incentive to improve. It is critical that the following questions be asked. Was the hospital-acquired infection preventable? Remember, with preventability comes liability. And secondly, was the evidence-based standard of care met? Remember, in law, the burden of proof is on the clinician or healthcare provider to prove that they have done everything possible to protect their invitee or patient from adverse events. This means incorporating critical thinking and current technology along with patient values into the care provided to ensure adverse events do not occur. The importance of keeping current cannot be overstated, as malpractice standards change, not because of changes in the law, but because of changes in products, practice, or technologies, which require that clinicians stay up to date with improvements to protect their patients. In malpractice cases, the question often becomes, was there some product, practice, or technology that could or would have resulted in improved patient outcomes or fewer adverse events with minimal risk, liability, cost, and training, and if so, why weren't they used?